Renal infections. So this is a very important topic, and here we shall be limiting our discussion to your renal and perinephric abscess, xanthogranulomatous pyelonephritis, emphysematous pyelonephritis, your renal tuberculosis, and your vesico-ureteral reflux. So let's begin our discussion with your renal and perirenal abscess. It usually occurs as a result of an ascending UTI in association with an underlying urinary tract abnormality such as your obstructive uropathy or your VUR. Now, this is caused by your uropathogens such as your E. coli and your other gram-negative bacilli. Now, renal abscess may actually extend and perforate the renal capsule to form your perirenal abscess. Now, they may multiple renal abscess may actually conglomerate to form a solitary separative lesion. Now, this is called your renal carbuncle. Now, it is caused by your Staphylococcus aureus and which reaches the kidney by your hematogenous route. Now, the clinical presentation may be insidious, or the patient may be presenting to you with a back pain or an abdominal pain or costovertebral tenderness. The urine examination in such patient is usually normal until your abscess communicates with the collecting system where you would find your signs of infection. Now, the investigation of choice to establish the diagnosis is your CECT scan, and treatment with antibiotics without drainage may be effective in specific patients where your abscess is small, that is less than 3 centimeter, and in case of stable patients with your abscess measuring up to 5 centimeter. The empiric antibiotic therapy should be a broad spectrum and cover your staph aureus and your uropathogens causing complicated UTI. Now, the culture directed antibiotics may be needed for at least 2 weeks or longer depending upon the response that your patient shows. Now, the percutaneous aspiration or drainage of pus is indicated when you have abscesses more than 5 centimeter and in patients who do not respond to your antibiotics. Now, open surgical drainage is usually not needed, and it is done only when your percutaneous drainage is inadequate. Now, moving down to the next topic, which is the emphysematous pyelonephritis. So, it is an acute onset, rapidly progressive, possibly a lethal form of your pyelonephritis, which is characterized by your parenchymal necrosis and your gas formation. Right. So, these are your few clinical clues in your clinical based scenarios where you can form a diagnosis of your emphysematous pyelonephritis. Now, the organism causing include E. coli, Klebsiella pneumoniae, Pseudomonas aeruginosa and Proteus mirabilis. Now, most patients have diabetes, around 90%. So, again another important clinical clue in your question, and they may have obstruction secondary to your calculi or your papillary necrosis. Investigation of choice is again a CECT whole abdomen, which would show your gas in renal parenchyma collecting system both, along with the other features such as your abscess, obstruction and perinephric stranding. Now, early diagnosis, intravenous broad spectrum antibiotics, percutaneous drainage of the abscess on the obstructive kidneys have improved outcome in this patient, and emergency nephrectomy is rarely required and is reserved only for those patients who do not respond to the treatment. Now, moving down to the next is your xanthogranulomatous pyelonephritis. So, what it is? It occurs when your severe renal infection in an obstructed kidney, and it is usually associated with your calculi causing loss of function and parenchymal destruction. Now, the pathological examination would typically show your lipid-laden foamy macrophages, and the patients may present with your flank pain, fever, chills, persistent bacteriuria and a flank mass. A history of stone disease may be present. It is usually unilateral, and CECT of the abdomen is your diagnostic and shows a non-functioning obstructive hydronephrotic kidney which is enlarged around with a shrunken pelvis. Right. Now, this is also known as your bear's paw sign, which is seen on your CT scan. A bear's paw sign on your CT scan, and your definitive treatment is your nephrectomy. Now, we have your renal tuberculosis. This is a very important topic. It accounts for around 15 to 20% of your extrapulmonary cases of your tuberculosis. It is caused by your hematogenous route, is usually secondary. Now, the hematogenous spread occurs of the tubercle bacilli from the thoracic lymph node or the lungs. Now, it is usually a result of reinfection or the reactivation of your old TB granulomas. Your blood-borne microorganisms are deposited close to glomeruli, causing an inflammatory reaction. Now, there are a lot of changes that occur in your renal tuberculosis, which are usually asked in your exam. So, we need to remember that. So, this inflammatory reaction, the macrophages react and the granulomas are formed. Now, if this bacteria multiplication goes unchecked, it causes your caseous necrosis, which results in the formation of your tubercles. Now, this multiple tubercles coalesce and rupture into the collecting system, causing your intermittent tuberculous bacilliuria and pyuria. Now, this disease spreads to the collecting system with ulceration initially. When bacterial multiplication is halted by your immune system, what happens is that fibrosis appears. Now, your tubercular obstructive and destructive lesions in the kidney and ureter are responsible for your renal function lost, and involvement of bladder is usually secondary to your renal disease. So, this is a beautiful diagram which has been taken from your Bailey and Love standard textbook. So, if you look over here, these are your various changes that occur. So, first you have your Kerr's king. So, what it is? It is your fibrosis at your renal pelvis causing your pelvic ureteric junction to be hiked up. You can see over here. So, this is your Kerr's king. Now, if you look over here, this is your putty kidney. So, what is your putty kidney? There is an extensive dystrophic calcification involving all or most of the kidney, seen as calcified non-functioning renal tissue. So, this part is your putty kidney. Then, if you look at this ureter, it is like a pipe stem, right. So, this is the straightening of ureter as a result of fibrosis on the wall of ureter. So, there occurs fibrosis which causes the ureter to look like a straight pipe, and hence it is your pipe stem ureter. Then you have your corkscrew ureter. So, if you see over here, multiple annular structures which occur along the length of the ureter. Then a golf hole ureteric orifice. So, if you see over here, the ureteric orifice may become patulous and may be pulled up, right, and the tubercles are usually infrequent in bladder. So, this golf hole ureteric orifice, because of the ureter becoming patulous and it becomes pulled up, it looks like a golf hole ureter. Now, you have this calyxis over here which looks like a fuzzy calyx or your moth-eaten calyx. Now, please remember, this is also your earliest radiological sign seen in your intravenous urogram. Then your caseous necrosis, as we had discussed priorly. Then you have your ureteric strictures, and then the secondary involvement of bladder, which is your thimble bladder. Now, this is also responsible for your urinary frequency, which is actually your most common symptom of your genitourinary tuberculosis. Now, so please do remember this particular changes. Normally the questions are framed from this particular diagram itself. There have been incidents of your putty kidney being asked with the image and almost consecutive sessions on your last two needs, right. Now, for the microbiological confirmation, we need at least 3 consecutive early morning specimens of urine. So, please remember, it is not the midstream urine, it is rather your 3 consecutive early morning specimen. The gold standard for your diagnosis is your urine culture. Then you have your nucleic acid amplification test, which provides your rapid diagnosis. So, this diagnosis remains uncertain. Then you need to do a bladder biopsy, tissue culture and tissue nucleic acid amplification test. So, Another few important points which I would just want you all to remember and go through is your imaging with your CT urography may show early signs such as your calcial distortion and papillary necrosis, features of hydronephrosis. IV, you can pick up the earlier signs of disease activity, which is your calcial distortion, and your treatment is usually a short course of antituberculous therapy, and your drugs which are used are your rifampicin, isoniazid and pyrazinamide. And then you have your percutaneous nephrostomy, which is recommended to obliterate your strictures to achieve prompt decompression, and definitive surgery is usually done 3 to 6 weeks after ATT. And your choice of your reconstructive procedure depends upon the type and the location of your sequel. Now, open surgical repair is generally superior to your balloon dilation of your tuberculous strictures, right? And you have your augmentation enterocystoplasty, usually ileum, for small capacity bladders, where your ureteric implantation with or without a Bory flap, that is a bladder tube for the lower ureteric structure, and ileal replacement of the ureter along with the multiple long ureteric strictures may be required, right? So these are your surgical options which will be only required when you have those complications such as your ureteric strictures and your dilation. And nephrectomy is done only for your poorly functioning kidney. So this were the images that have been asked. So if you can see over here an X-ray image demonstrating your putty kidney, and this is your CT scan image demonstrating your putty kidney. They have been just asked as your spot diagnosis, so please do remember regarding your renal TB. Now, next very important topic in your renal infection is your UTI in children and your vesicoureteral reflex. Now, this UTI is approximately seen in 7% of childhood febrile illness. At an age group of less than 3 months, it is much more common in males, whereas in an age group of more than 1 year, it is much more common in females. It predisposed to your UTI. The factors that predispose to your UTI includes your vesicoureteral reflex and your posterior urethral valves. And your most important complication of your UTI is your renal scarring. So the most important topic over here is your VUR. So let's understand what is your VUR. Now it may be a primary or a secondary vesicoureteral reflux. Primary, when it occurs, is because of your short intravesical ureter, which is due to the inadequate closure of your ureteral vesical junction, whereas secondary is due to the elevated intravesical pressure, mainly due to your posterior urethral valve or your neurogenic bladder. Now, the investigation of your choice to diagnose is your voiding cystourethrogram. So, if you can see over here the image, it is showing your right-sided vesicoureteral reflux. Now, another important question that is asked is your for renal scarring. So, for renal scarring, you have your technetium 99 dimercaptosuccinic acid, which is used. Now, for VUR, it is around 30% in children with UTI and around 90% children with renal scarring it is seen. So please remember this important data of VUR, which is like associated with around 30% of patients with urinary tract infections and 90% in children with renal scarring. Now this is your grades of your vesicoureteral reflux. So if you look at your grade 1, now it is a reflux into an undilated ureter. So over here you can see your ureter is not dilated. Now again, if you see in grade 2, it is again a reflux into ureter and the renal pelvis. So you can see the reflux reaching over here in the renal pelvis, but at the same time the ureter is undilated. Now grade 3 is a reflux causing into mild to moderate dilation of the ureter, renal pelvis, and mild phoneal blunting of the canesis. You can see over here there is starting of the blunting of your phonesis. Then we have your grade 4, which is a reflex causing your moderate ureteral tortuosity and your pelvic calcial dilation. So you can see the tortuosity that starts beginning, and your grade 5 is your gross ureteral tortuosity and a gross pelvic calcial dilation with the loss of your papillary impression of your calyces. So this is your grade 5. You can expect an image based question coming from here where they ask you regarding your grades of your VUR. So the treatment would be your low dose nocturnal antibiotic prophylaxis to prevent your scar inducing pyelonephritis, as majority of them resolve on its own, and surgery is usually reserved for your severe reflux and which recur despite your antibiotic therapy. What is your surgery that you need to do? A ureteric implantation or a periureteric injection of the Teflon or collagen has found to be useful. So this were your important points regarding your renal infection. The most important that you need to remember includes your renal tuberculosis and your vesicoureteral reflux. Thank you.